We're going to start the plenary. I'd like to acknowledge that we are on Treaty 1 territory and the homeland of the Métis people. My name is Mona Lutfi. I'm an infectious disease specialist and researcher from Toronto. And I have had the pleasure of being co-track chair with Yoav Keenan. And Yoav, it's been a real pleasure. And so I'm going to invite up our clinical sciences plenary speaker, Dr. Jared Baeten. Dr. Baeten is vice chair and a professor in the Department of Global Health at the University of Washington in Seattle. I just learned that he's originally from Green Bay, Wisconsin, which is my husband's favorite football team, so that's good. Jared is well known around the world for research in HIV and STI prevention. He has done some incredible trials, the most famous ones being related to PrEP, including he was the co-chair of the Partners PrEP study, the Partners demonstration study, and the Aspire Dopinavir ring study, and is probably the only person I know who's gotten a standing ovation at CROI. So it brings me great pleasure to invite Jared up.
Good morning, everybody. How are you? It's lovely to be here. Flying in to Winnipeg is a lot like flying into Green Bay, because it farms and then there's the town. And it does snow in May in Green Bay as well. I don't know if I'm supposed to mention that or not. It's really great to be here today, so thank you for inviting me. So I have no disclosures. So I titled the talk PrEP at Age 5, Growing Up Fast, trying to think of a way to frame talking about PrEP to this audience and reflecting a lot on where PrEP has gone in the last 5-6 years. So PrEP is somewhere between 5 and 6 years old because the first results for PrEP clinical trials came out in the end of 2010 and then in 2011. First in men who have sex with men with the IPREX results, and then in heterosexuals, including our partner's PrEP study, among others, with the great recognition that you want, publication in Time, which is the pivotal achievement for our scientific outputs. And then in the United States, the US FDA approval of branded Truvada for PrEP. And this great quote that I love from Deborah Bergkrant: "It's still better to prevent HIV than have a lifetime of treatment." So I've been thinking a lot in the last several months about what it means to be 5 or 6. And I started thinking, what do we expect of a 5 or 6-year-old? And of course, I think about this a lot because I have a 6-year-old. This is Audrey, in a great moment that 6-year-olds sometimes have. And I did a lot of searching to think about what I should be expecting for someone who is 5, 6 years old. And I went to those reputable medical sources, WebMD, my own government, and of course, the government of Manitoba, which provided information on what I should be thinking about when I think about a 5 or 6-year-old. So at the bottom, you can see that the government of Manitoba, I searched their website for what a healthy child should be developing as a 5 and 6-year-old. And these are the things that 5 and 6-year-olds should be thinking about, and this is how I'm going to talk about PrEP today. They begin to understand cause and effect. Magical thinking begins to fade. We start to understand the feelings of others, become more flexible in our thinking, and understand more about our place in the world. And I'm going to frame how we think about PrEP because PrEP has grown now in many ways under all of these, in these varieties. So it's developing appropriately for someone who is 5 or 6. So let's talk at the beginning. Begin to understand cause and effect relationships. So what is important with PrEP, and thinking about this, is that if you take PrEP, you don't get HIV infection. PrEP is effective for preventing HIV, in fact, incredibly highly effective for preventing HIV. And let's think about what that means in terms of causes and effects. We have 6 clinical trials that demonstrated the efficacy of PrEP versus a neutral comparator for the prevention of HIV infection. And you can see they range from the first publication at the bottom, the IPREX trial among men who have sex with men in 2010, to the 2 trials in heterosexuals, partners PrEP and TDF2 in the middle in 2012, to the Bangkok-Tenofovir study, the second line from the bottom, among injection drug users in 2013, and then most recently, once the efficacy of PrEP had been demonstrated, the IPRGAY trial testing a different distribution of PrEP, and the PROUD study, an open label but still a randomized trial. So with 6 clinical trials, a tremendous amount of evidence, much more than we normally have for health interventions, we have demonstrated that PrEP works for HIV prevention and can work in neutral comparisons between 44 and 86%. You line these up, though, it's not 44 to 86%. It's a line that associates the relationship between PrEP and adherence to PrEP. With IPREX to the furthest to the left, with about 44% efficacy in its randomized comparison, relating to about 50% adherence in that blinded clinical trial. And in studies then marching up thereafter, with higher adherence, higher HIV protection was seen. Most notably, the IPRGAY and PROUD studies, which were done quite a bit after these other 4 trials. Those recently completed trials, which were done after it was well known and publicized that this medication was efficacious and safe for HIV prevention, they had the highest adherence and, as a result, the highest degree of HIV protection. At the same time, of course, we know that in the absence of good adherence to PrEP, HIV protection was not and cannot be seen. There are 2 trials, FemPrep and Voice, with very low adherence, and in the absence of adherence, of course, one cannot expect that PrEP would be working. The top of my slide reminds, I use a plural when taken they work because this is the same situation, of course, that we have for antiretroviral treatment when we think about treatment for HIV prevention. Treatment cannot possibly work in the absence of use, and treatment works extraordinarily well when used. The HP10052 study, all the farthest to the right, had incredibly high adherence and very high HIV protection. Real-world effectiveness and real-world adherence are somewhat in the middle, actually right in the middle of the rest of those PrEP stars, with about 64% effectiveness in a meta-analysis. So this is at the trial level. Trials that had higher adherence had higher degrees of HIV protection, cause and effect. This also operates at the individual level. In 2 of the clinical trials, Partners PrEP and IPREX, there were initially analyses done at the individual level that associated HIV protection with taking of PrEP, with about 90% HIV protection seen for those who had PrEP detected in their blood. And we'll talk about this a little bit more in a few slides when we think about what is good enough, but this is the first association that there's cause and effect that if taken, PrEP can work extraordinarily well. Subgroup analyses from these clinical trials have also shown that PrEP is effective for those who are at greatest risk, a question that is incredibly important when we think about how to translate clinical trial results into the implementation of PrEP for HIV prevention in real-world settings. In the Partners PrEP study, again among heterosexuals in East Africa, we did analyses to associate PrEP protection among those who had higher risk characteristics, those who openly admitted to sex without condoms, those who had STIs, those whose positive partner had higher viral loads and thus a higher force of infection to protect against, women who were younger and women who used types of contraception that might enhance their HIV susceptibility. Within the IPREX study, they did similar analyses among men who used cocaine, who had syphilis, who reported unprotected anal sex with an HIV-positive partner. And in all of these analyses, sub-analyses, HIV protection estimates were the same or even higher than they were for the population as a whole because adherence was often greater for these higher risk persons, cause and effect. At the same time, when we think about the IPREX when we think from IPREX and then moving into the IPRGAY and the IPRGAY and the PROUD studies, we also see the same sort of results, that in higher risk populations, we can see incredibly high HIV protection. Before I conclude this first section on cause and effect, I want to make one caveat on cause and effect. More medicine does not necessarily equal more protection. While there is, and this is something that's quite different for PrEP than for treatment. In treatment, of course, more medicine, at least when we get up to 3 and sometimes with a boost 4 medications, is necessary to achieve suppressive viremia for persons with HIV infection, as well as to achieve prevention efficacy. That may not be true for prevention in persons who are HIV negative. We have one trial, Partners PrEP, that directly compared one drug for PrEP, tenofovir alone, compared to the combination, tenofovir and tricytidine, and found comparable results, 67% and 75% compared to placebo. And indeed, when both of these are reanalyzed against a detection of PrEP in blood, they're both at about 90%. So it changes our paradigm of what we think is enough for PrEP for HIV protection, where one drug could be enough. For countries where costs are important, and I don't know if there's any country in the world now where healthcare costs are not important, but it may mean that we are not looking at having to always increase the number of drugs to achieve highly effective prevention from PrEP medications, be it from a tenofovir-based medication or in the future from other types of PrEP agents. Because what we can see is that tenofovir alone and tenofovir and tricytidine might be enough, or for countries who are looking at cost-saving measures, potentially even tenofovir 3TC, its analog. So we have begun to understand cause and effect, that when taken, PrEP works for preventing HIV infection. This has not been an easy learn. 6 clinical trials demonstrate efficacy, 2 did not demonstrate efficacy, millions of dollars spent to understand that you need to take medications in order for them to have preventative effects. But now that we know that, we have a framing for how we can think about how to deliver PrEP for HIV prevention and how we can deliver PrEP in ways that are good enough that we achieve what we want, which is not perfection, but which is people not getting HIV. And so that brings us to the second point, magical thinking. If you've had a child, you know children, you know that there's a lot of magical thinking. Magical thinking, I think, persists in us as well as adults. And when I've been thinking about PrEP for years, I've thought about the magical thinking that's gone into the development of PrEP. It would be perfect. It would be horrible. It would change the world. It would destroy the world. And I think you may have had the same conversations. I came in too late last night to talk about your guidelines development, but I'm sure those polls have been discussed in every guidelines development I've talked about for PrEP, and I'm sure they might be discussed here. We also think about perfection. I'm an infectious disease trained doctor. I'm sure many of you are as well. We are persnickety people, and we like perfection. But perfection has not helped us in all cases for treatment. It has helped us get good medicines. We have the best medicines for HIV treatment, but we've also at times withheld those medicines from persons with HIV because they weren't perfect enough for us to provide them. PrEP has faced the same. We've wanted perfection, but I think that magical thinking has begun to fade when we look at the data for PrEP. This is what PrEP data look like. These are data from Partners PrEP. These are among heterosexuals, and this is what their adherence looked like. This graph is broken out blue and orange. The orange are individuals who their first month after starting PrEP didn't have any of it detected in their blood. Those orange individuals, you can see, tend not to take it any time thereafter. People have become consistent in their habits around PrEP. The blue individuals are individuals who had PrEP detected in their first month after starting it. And you can see most people in blue stay up in that detected line long thereafter, for up to 3 years after initiating PrEP. A few of the blue people drop down to undetectable with PrEP, but it's not the majority. In fact, it's not most at all. And in fact, in Partners PrEP, many of those were women who became pregnant for whom PrEP was withdrawn from them, because we did not test PrEP in pregnancy within that clinical trial. So adherers generally stuck with it, at least until they discontinued, and non-adherers rarely started adhering. Similar information was seen within the IPREC study, where people were generally adherent, here in orange at the top, or non-adherent, those in green at the bottom. And the distribution was a little bit different in IPREC. Their adherence overall was generally lower, although in the open label studies in MSM that have followed, this changes much more to a graph that looks like the former graph. And if you've ever done preventative therapy yourself or prescribed it, you know that people who are adherers generally tend to adhere, and those who are not generally don't. But people who get into rhythms stay in the rhythms for prevention. And if you are, I won't make people raise hands, but if you are a flosser, you know who you are, and you know you generally stick with it. And if you are not, you generally don't. And oral contraceptives may be the same. No raising hands. We will not do any of that here this morning. Oral contraceptives generally are the same, and we'll talk a lot more about that later because I think the analogy to contraception is quite important. We want perfection, of course, with HIV prevention. We want perfection with HIV prevention, of course, because we want no more HIV infections. But we don't need people to be perfect to achieve HIV prevention when we're talking about PrEP, it seems. These are data from the IPREX-OLAY study, the open-label extension that followed IPREX, where they found that 100% HIV protection was seen even in men who were trying their best, but only achieved about 4 doses a week of PrEP instead of course, 7. And that has really changed our thinking about what PrEP can do, that people can be people, do their best, and if they achieve pretty good taking of PrEP, they don't get HIV infection. And I think we see this, we'll talk about this in a little bit in terms of demonstration projects, and I think we're going to be seeing a lot more of this as demonstration projects begin to report their results within this next year. Indeed, we've seen that one need not have there is good data, randomized clinical trial data even, that show that PrEP need not be prescribed every day. These are data from the IPREX study done in France and here in Canada that found that intermittent use of PrEP, that is prescribed 2 doses before a sexual act and then for 2 days after a sexual act, with an average of 16 pills used a month and against a very high HIV background rate, had near complete HIV protection. 86% protection in that clinical trial before it was discontinued, before the use of placebo in that trial was discontinued, and only 2 infections occurring, both of which were in individuals who were clearly not using PrEP, who had declared that they had stopped using PrEP. So arguably 100% in individuals who still had access to PrEP. For heterosexual populations, a group that I think about a lot because we do a lot of work in East and Southern Africa, a predominantly heterosexual epidemic, there are suggestions that the bar for what needs to be good enough may be a little bit higher than for rectal exposure. Here are data on the right from pharmacokinetic studies suggesting that the female genital tract needs a few more doses than 4 per week to achieve very high HIV protection. At the same time, however, we know from clinical trials in heterosexual populations that those were done among real people who had real pill taking. In our Partners PrEP study, we found data that our data suggests that adherence about 80% or more might be associated with 100% HIV protection. So one can strive to be perfect and achieve 100% protection by being human at the same time. We also want protection in terms of safety, and certainly the bar is high for safety for prevention. And we have a different bar for safety for prevention than we do for treatment because many of the people who will take PrEP will never get HIV, even if they did not have access to PrEP. And that is always what we think about when we're doing preventative therapies. Same thing that we do with for treatment of hypertension and high cholesterol is that we're preventing things that may happen to individuals. We want these drugs to be safe, but we have evidence that these drugs are safe. From the clinical trial data, these are data from both Partners PrEP and IPREX, we see that tenofovir-based PrEP results in small but non-progressive declines in both GFR for renal toxicity and in bone mineral density for bone toxicity, both of which reverse when PrEP is finally discontinued, as it is expected to be for all individuals taking PrEP, and does not appear to result in a substantial increase in relevant toxicity that is clinically important. We also know that antiretroviral resistance has been extremely rare out of PrEP clinical trials and now out of PrEP demonstration projects, and seems to be limited to those with acute infection when starting PrEP. Also, I'm a public health practitioner. Importantly, we have to remember that we do PrEP for public health benefits, and resistance risk is dwarfed in PrEP by the number of individuals protected against PrEP. One comparison within our Partners PrEP study is 2 to 5 cases of antiretroviral resistance within that trial, depending on with the degree of sensitivity of resistance measurement that one has, versus 123 HIV infections that we know we prevented based on the randomized evidence. And indeed, even those 2 to 5 individuals, that resistance faded within the first 6 months after PrEP was stopped. And there's mathematical modeling data that have emphasized that resistance risk will be rare at a community level contributed by PrEP because of resistance risk that is already being accumulated because of ART rollout. So when I think about the magical thinking, I've thought about perfection a lot in terms of PrEP, and of course I've wanted PrEP to be perfect in terms of its effects and its safety, and it's pretty good, actually quite good, and you don't have to be perfect to be really good and good enough for having a major public health benefit. 5 and 6-year-olds also start to understand the feelings of others, and this is one where I think PrEP has revolutionized a lot of our thought, because PrEP has begun to make us have conversations that as HIV practitioners, as primary care providers, as public health practitioners, we haven't had in a long time. People who take PrEP tell us that PrEP gives them things that are important to them. It reduces their anxiety, increases their communication and trust with partners. It improves their self-efficacy and improves their sexual power, pleasure, and intimacy. Conversations that we do not have as practitioners nearly often enough, certainly within HIV settings, there's good evidence of that, and certainly that we have not had in primary care settings, and we've not had in public health in a very long time. Here's a quote from a qualitative interview among an IPREX-LA practitioner. "We all have our slips sometimes when we really don't take, the safest route. And while that may be a sexual risk for this individual, it may be a seatbelt risk for some of us, or perhaps other decisions we make when we travel or go to conferences where we don't take always the safest route all the time. But we all try our best, and sometimes we need a little bit of extra boost to make us be safe." PrEP has revolutionized advocacy around prevention and changed our messaging in wonderful ways. These are slides for early shaming around PrEP with the term Truvada whore that was then re-embraced and re-shot back out at those who would shame around PrEP by individuals who were taking it. We've seen public health practitioners talking about PrEP in ways that are amusing and potentially life-affirming and life-changing, ways that are a little bit more risque, or from our friends in Australia, where ones that really respond to communities and are even more risque. And that's what we need for people to want to respond to wanting a preventative strategy that works for them. Not everybody's perfect with PrEP, and this is what we will continue to find. In PrEP clinical trials, the factors associated with non-use included younger age, lack of social support, low perception of risk, and not coming to appointments, and of course, this is to be expected. This is what we know from treatment adherence as well, that these are challenges. But challenges do not make us say that these factors do not allow someone to start treatment in the first place, nor should they prevent every single person from taking PrEP. Also, we'll talk about this later, not having sex has also been associated with lower PrEP use, which I have to say in clinical trials of PrEP seemed like a really good decision to make. And for distribution of PrEP, that of course is a good decision to be making. An important barrier to PrEP, and one that needs a lot more research, is stigma. About antiretrovirals, about HIV, about being seen as having HIV potentially, or being at risk for HIV, as well as lack of access to PrEP and shame and hesitation about asking providers for PrEP. This is one abstract from a couple years ago. 76% of men in Boston who were receiving PrEP, so at a clear risk for having to be initiated on PrEP, were interested in taking it, but a third of them did not feel comfortable talking to their provider about it at all. And as HIV providers and as persons who are moving PrEP into communities, we have to think about making these conversations easier to have so that people can get access to a life-saving service. So a lot of the social behavioral research related to PrEP has made us start to understand that the feelings of others, the feelings of those who might want PrEP, and that PrEP is a wanted strategy for populations at risk, and populations at risk globally. The data that I showed you brought in information from Seattle, San Francisco, Australia, South Africa, Kenya, and Uganda, and other places. So it is a cross-global wanting of a prevention strategy that works. PrEP also is making us more flexible in our thinking, and that becoming wanted is a transition to becoming more flexible in how we think about PrEP. PrEP pushes us to think differently. For PrEP and for treatment as well, providers not providing good information, unclear messaging or judgment, and discomfort in talking about sex or drugs or mental health have limited achieving best prevention benefits. And I think we've got good evidence of this for treatment, and we have many patients now telling us this for PrEP. And PrEP pushes us to think differently. I like the sign at the bottom. This is a sign from Seattle. The odds are good that your goods are odd. Does that translate into French? Not as well, I think. PrEP makes us think differently because it's not the same as treatment. For those of us who are routinized into providing antiretrovirals for treatment, PrEP is something different. Treatment is uniformly needed for every person with HIV infection at some point in their life, and hopefully earlier as more people get into treatment, earlier because of earlier testing and earlier conversations about treatment. And then it is for the rest of their life, and there are currently no alternatives. PrEP is completely different. PrEP is only for a subset of individuals and only for a subset of their lives, only for periods of high risk when other alternatives are not sufficient. That's a totally different conversation to be having, and one that none of us are quite practiced at yet. Thus, PrEP offers an option for persons and periods in their life when other prevention options are not enough. For women and men who have ongoing or time-limited risks, when PrEP gives self-efficacy over prevention. Or for couples, for example, a population that I've spent a lot of time working on, as a bridge to the infected partner taking treatment, and perhaps in periconception or pregnancy periods, when risk may be greater or the benefits of PrEP might be even more enhanced because you're preventing infection to both the mother and to an infant. Again, PrEP and treatment are different, and they're different not in terms of both in terms of what they are and in terms of what adherence means, and I want to talk about this as well. Treatment adherence is lifelong and without breaks. And I think we've got excellent evidence now from a number of years that treatment breaks are not as good as continuous treatment. And sustained adherence is necessary to maintain viral suppression. PrEP adherence is different. PrEP adherence needs to map to those periods in life when there are risks. But PrEP adherence need not be there if risk is not. And so breaks can happen, and it is perfectly safe for breaks to happen in PrEP adherence if it's mapped well to when there is no risk. Because success in PrEP adherence is achieved when PrEP is used during episodes of HIV exposure, a concept that's being knocked around with the term prevention-effective adherence, aiming that adherence to those periods when it's going to have the most prevention effect. Thus, adherence to PrEP might be periodic, and importantly, PrEP use should be expected to stop at points. It is not a lifelong therapy, it is an on and off therapy. Figuring out how to do that well is something that none of us are fully experienced in yet, but something that I think we'll learn how to do. And something that we have some analogies of how to do that I'll talk about in a minute. We also have to think about other risks, and this is, again, becoming flexible in our thinking. STIs will occur for people on PrEP. This is a topic of great discussion now. What is the STI risk that's going to happen when PrEP is rolled out? STIs will occur for people on PrEP, I assure you. These are what the STI rates look like. This is from the CAHR study in San Francisco and around there in California. This is the 12-month cumulative STI percentages in men who are taking PrEP there, with 50% having any STI, and those are combinations of gonorrhea, chlamydia, and syphilis, but no HIV infections. And we have to remember that the goal of PrEP is to prevent HIV infection. The consequences, or the coming along with no HIV infection may be STIs. But that may not be because of PrEP itself. These are the STI rates in men who started the PROUD study before they started the PROUD study. 25% with rectal gonorrhea in the 12 months prior to starting the PROUD study, 20% with rectal chlamydia, 25% with urethral gonorrhea, and on and on. The individuals who need PrEP are those who have high STI rates before they start PrEP. And so high STI rates on PrEP are not necessarily a consequence of PrEP, but a consequence of making sure the people who need PrEP the most are getting it. The evidence so far argues against significant new risk-taking with PrEP. In the clinical trials, we saw a decreasing frequency of unprotected sex during IPREX and Partners PrEP, potentially as a result of continuous engagement in care and continuous risk reduction that result in behavioral change that can be sustained. In the open label extensions that happened after these trials went on, there was no increase in risk-taking once the efficacy of PrEP was known. So PrEP, individuals who were already at high risk did not further increase the risk, and individuals who were at lower risk did not increase their risk to match those who were at higher risk once PrEP efficacy was known in those clinical trials. And indeed, PrEP and treatment have their greatest benefits for those who are already not using condoms. That is, it reduces risk ultimately, rather than makes risk occur. This is a hard conversation to have because this is opening up new conversations with patients that we have not had to do very often so far. PrEP won't be perfect. This is the case report from Canada. I have heard mumblings of case reports from other places in the United States as well that PrEP won't always be perfect. This is a breakthrough infection that occurred here, but a rare event to a resistant virus, probably from an individual who had multi-class resistance and transmitted multi-class resistance that broke through PrEP. A rare event does not diminish the substantial prevention benefits that PrEP offers. And we have to think about having conversations, again, about trying to aim for perfection, but realizing that perfection cannot be achieved. You have had these conversations yourself, although you may not recognize it now, in primary care. Here's the IPREX data, presenting this as a primary care strategy. IPREX PrEP, a daily pill for HIV prevention, for a population with a 4% annualized incidence of HIV, which would consider to be a high risk of HIV, and thus needing PrEP, with a 44% reduction overall in the degree of HIV protection and 90% overall in those who were adherent to PrEP. And a number needed to treat 62 overall, 30% among those with unprotected rectal anal intercourse, and 15 among those with higher risk. That's conceptualizing the numbers around PrEP. 44% overall, 90% with high adherence, and numbers needed to treat that look like this. Every single clinician in this room has prescribed a statin for HIV prevention. And I present here the West of Scotland study, which was the original study that talked about statins for primary prevention of HIV, as well as the recently published HOPE-3 study, giving a nod to Canadians who led this study, for low-dose rosuvastatin. With placebo frequencies of outcomes on the order of 1 or 2%, relative risk reductions of 29%, and numbers needed to treat of 200 to 400. And no one in this room who's provided a statin has ever fretted as much about adherence to a statin or fretted about perfection as much. I've never told a patient of mine, here you're starting your Lipitor, I promise you'll never have a heart attack, as we might be fretting about PrEP for HIV prevention. Because PrEP is much like, I would argue, another commonly prescribed primary care prevention intervention. Oral contraceptives were initially approved, like PrEP, for treatment of a condition. PrEP is approved for HIV treatment. Oral contraceptives were initially approved for menstrual disorders, but were then reconnoitered into a prevention strategy. They offer both individual control over prevention, have concerns about sexual behavior, adherence, and side effects, and while perfect use is the ideal, real-world use has individual and population benefits. And we arguably have to start thinking about PrEP more analogous to this kind of prevention strategy than we think about it according to HIV treatment. Because prevention of oral contraceptives is done in settings that are much, much less controlled than we have for HIV treatment. PrEP will need to make us think differently. And finally, we need to understand more about our place in the world. What a difference a few years makes. So this is 2013, an article in The New Yorker with a great title, Why is No One on the First Treatment to Prevent HIV? This is PrEP begins to roll out. And this is a few weeks ago in the reputable journal, the Gay Star News, where a new app in San Francisco will deliver PrEP meds to your door in 24 hours with no doctor's visit required. What a change, right? That maybe not be the ideal distribution of PrEP, but what a change to have something move from not being used at all to being used a lot now. And at least where I come from Seattle and from the United States more generally, particularly in the major urban centers where there are large gay populations, PrEP use is now very highly used, with hundreds and hundreds, and now thousands of persons taking PrEP on a daily basis. Moving in this diffusion of innovation cascade, where people start early, move to early adopters, which is where PrEP has moved, and now perhaps, especially in cities like San Francisco, moved out of early adopter stage into a larger coverage. In the United States, of course, we've had guidelines since 2014 for the provision of PrEP, guidelines that were designed to be simple. PrEP is indicated for those at high risk for HIV. Hard to operationalize what exactly that means, but what we've found is that individuals who are presenting for PrEP appear to be those who are at high risk. And so that we aren't having to weed people out from PrEP very often, that people who are seeking PrEP are those who are self-assessing appropriately. Eligibility and HIV testing and follow-up are simple. HIV testing, hepatitis testing, renal function, 3-monthly HIV testing. And that discontinuation of PrEP is to be expected. PrEP is not lifelong, but is for periods of high risk. Much in the same way that women going to Planned Parenthood in the United States are on, off oral contraceptives for periods in their life when there is risk to be had. WHO has recommendations that came out in 2015, and their guidance is expected in the summer of 2016. I was happy to hear about your guideline development yesterday. There are many questions about PrEP, and no one has all the answers for these, and every setting has to figure this out. Who is going to prescribe this? To whom will it be prescribed, and where can it be prescribed? We've wrestled with this a lot. In my own city in Seattle, we had hundreds and hundreds and hundreds of people on PrEP at private doctors' offices before the Public Health Service began providing its very first PrEP in our clinics. That private doctors and the ability to achieve PrEP was achieved long before public health was able to provide PrEP. Do people who might benefit most from PrEP want it? Do they take it often enough? The early demonstration studies that I'll show in a minute are showing that. And then what is its impact in terms of incidence, resistance, and costs? And we have suggestions of that information from cities like San Francisco, which are seeing dramatic reductions in HIV incidence with concurrent uptakes in HIV treatment as well as PrEP in the last 5 years. A few demonstrations. The open label demonstration study in the United States in San Francisco, Miami, and Washington, D.C. showed that 80% of individuals who were prescribed PrEP had levels in their blood sufficient for HIV protection. Condomless sex remained stable at 2/3 of participants. 2/3 of participants not having sex without condoms when they started, 2/3 of participants having sex without condoms when they finished. STI rates were high, as would be expected with all that, but HIV rate was low. Only 2 infections and an incidence of 0.4% per year, much less than one would expect in this type of population. In the PROUD study, which we've talked about a lot, which was a randomized trial, again, of open label immediate versus deferred PrEP, an HIV incidence of 9% per year in those who were denied PrEP in the United Kingdom versus an incidence of 1% per year in those who had it offered to them. That's the entire design of the PROUD study. Denied versus offered PrEP in a public health STD clinic in the United Kingdom. 86% effectiveness, and a number needed to treat of 13, which we rarely achieve in anything in health. In Kenya and Uganda, where we've been doing an open label demonstration project of integrated delivery of PrEP and treatment, where both can be taken, one can be taken, or neither can be taken. We see good uptake of ART, although sort of slow over the first year, sort of spreads over first year, and we provide PrEP during any period when a couple's not fully on ART. And in that strategy, we have seen a 96% reduction in HIV incidence from an anticipated incidence of over 5% per year to an observed incidence of less than 0.5% per year. Because ultimately, it's about coverage and delivery. This is a graph from UNAIDS up on the right that shows what global infections can look like with continuing things on as they are in blue, or actually having things at high coverage, which is in orange. UNAIDS has called for 3 million persons on PrEP by 2020, and PrEP is now just moving out of demonstration projects with regulatory approvals in now a number of countries, adding Australia to that list in the last few weeks, and PEPFAR beginning to implement PrEP now in sub-Saharan Africa. At the same time, choosing not to deliver also has its risks, and these are, of course, pictures from the United Kingdom, which is roiling right now about whether or not to deliver PrEP within their public health system. Because the risk is that we continue to have the same number of HIV infections. In this country and in mine, we have seen stable or even increasing HIV incidence over the last 10 to 15 years, even in the presence of very good drugs for HIV treatment and very good efforts to roll out treatment for testing and such. So that is not enough. In every country, important gaps in care and prevention create risk for new transmissions, emphasizing that comprehensive attention is needed to all aspects of both the treatment and the prevention cascades, where PrEP can add to that. And as we look forward, again, we will be needed to think that PrEP is not one size fits all. And there are many products in development. The pill, of course, on the farthest left is our first, but things like the vaginal ring, the dapivering vaginal ring, which had data this past February, and then injectable agents for PrEP, which are now moving into phase 3 trials, will hopefully find that there are prevention options that work for everyone in the same way that we have pills and shots and rings and other things for contraception. So I'm going to wrap up now, so there's a few minutes for questions. In conclusion, we've learned much, and we understand the place of PrEP in the world as we have learned much, we have much more to learn, we have much more to grow up, and much more to do. And I thank you for this opportunity to be up here today. Thank you.
We have time for a few questions, so. Good morning. Thank you very much for that presentation. I'm a community advocate, and you know what we're really working on right now is improving access in Canada. So let me just ask a simple question, because here we're going to have you know our challenges will be with provincial formularies, and we really want to improve the access through public reimbursement on our provincial formularies. What insights can you give us from your experience in the States around improving access, or what challenges are you continuing to face in the United States to make sure that the people who need it the most and are often the least able to afford it are getting access to PrEP?
From my experience in the United States, and then analogous, and then my experience as well in Kenya, South Africa, other places, is that access is the first and the biggest challenge to PrEP. Some of that is figuring out where that access should be, finding appropriate places for delivery of PrEP, and a lot of that is coverage. You know, we have a very different health financing system in the United States, with many flaws. And it differs by insurance coverage. The first persons to receive access to PrEP in the United States have been those who've had the very best insurance coverage. And they went to their private doctors and got it prescribed, and it did not get refused, and then that continued. At the same time, in different states in the United States, we've had public coverage of PrEP. So in Washington State, where I'm from, PrEP has had drug assistance coverage in the same way that we've had drug assistance coverage so that anyone can be on treatment in the state of Washington. Anyone who has certain risk factors can be on PrEP in the state of Washington. And we need to encourage those kind of strategies so that we are encouraging people to be on, giving the access opportunity for people to be onto PrEP. Because the cost effectiveness estimates are quite strong for different settings, including modeling for North American settings, when highest risk persons have access to PrEP. Because we're taking a time-limited, cost-effective strategy and preventing a whole lifetime of a quite costly and quite labor-intensive treatment strategy.
Hello, great presentation. I'm from London in the UK. I would argue that amongst many of my friends, they're self-medicating. They are doing exactly what you said in your presentation. They're phoning up and they're getting PrEP. Clearly, best argued that you get PrEP through your sexual health service. Do you have any thoughts about what happens when, particularly gay men particularly, are in effect self-medicating, working out their own strategies between themselves, and therefore bypassing people like your good selves?
It's okay if people bypass me, but this is a really good question. Like, how do we provide a prevention strategy in the real world, being fussy people like we are in public health and in HIV, but understanding that things move in real world settings? PrEP is at this interface. It is a drug that's developed within an infectious disease context, but is a primary care delivery type setting, and should, in my opinion, be moving in all of those settings. Delivering within HIV care context. My own HIV clinic, after a lot of roiling, now sees both HIV positive and HIV negative people, moving towards more of a community health type center, which I'm very pleased that we're doing. Primary care centers, STD clinics, sexual health clinics should be also places for providing PrEP. I think what the information that's most needed to provide is how to provide PrEP easily so that people want to have an engagement with the healthcare system to be able to get access to PrEP, so that the health interaction is not the burdensome part. What we want to avoid with PrEP, of course, is people using PrEP without HIV testing. Because that's the whole that's the major safety question, is that people use PrEP without HIV testing. They take inadequately suppressive antiretroviral therapy and don't engage in care early enough. That's the major risk for PrEP. The bone and renal toxicity risks are so small that those are not the first ones to think about. So how can we make systems deliverable and easy so that persons want to come in and engage in PrEP and want to engage in an easy system for PrEP delivery? When I think about what oral contraceptive delivery looks like, that is what an easy system is, where we think of something that maybe we prescribe for a period, and maybe we start figuring out strategies once we get going to make delivery even more easy for the long term. One of the things that we've been doing in Kenya actually for the last year is doing HIV self-testing at home in between PrEP visits, thinking about ways that Kenya, where resources are quite constrained, might be able to bump PrEP visits from monthly like they were in clinical trials to 3 monthly like they've been in the demonstration projects to 6 monthly like they are for HIV treatment, where one could do self-testing partway through as a strategy to not burden an already well overburdened healthcare system.
Thanks for a great presentation. To your point about ease, I'm just wondering what your HIV testing algorithm is, and how, if I presented to a community clinic in Kings County seeking PrEP, highly knowledgeable, HIV negative gay man of 30 years, how many visits would I have to do? And I ask because in Canada, we seem to be obsessed with laboratory testing.
We're obsessed with laboratory testing too.
Okay.
Yeah.
And point of care testing isn't readily available.
No.
So for example, you can't have an algorithm with 2 rapid tests.
This is a great question. How complicated do you make the system? And I think you have to scale the system to the place. You have to scale the system to what's available. So if you're in King County in Seattle, where I am, the access to antigen-based testing is pretty easy. However, in my clinic and in other clinics, we start people on PrEP same day with a rapid test or in combination with a send-off antigen antibody test, where we can get that result the next day and call someone if an antigen were positive. Because a day of Truvada is not going to make a substantial difference if someone can get that result back the next day. At the same time, I'm on the National Medical Board for Planned Parenthood, where they're thinking about all of their distribution of PrEP and all of their settings, including very small rural places in the United States where an antigen test can't come back the next day, where they do rapid tests, and that's okay too. And that's what we've done in Kenya, is doing with rapid testing. Limitations of not detecting acute infection are there, but the overall public health benefits are far outweighed by getting people onto PrEP and not setting up barriers. Because if you set up a repeat visit, you'll still have the same question that people may get HIV in the period between every repeat visit. So trying to get as good of HIV testing as you can, but not say that an entire place can't have HIV testing because they can't get their lab to be better. That seems wrong to me.
For an engaging discussion and a wonderful presentation. And here's a small token of appreciation on behalf of
Oh, look at this, I get a present. Thank you. Thank you.